So thank you for joining the OncoHost virtual dinner program tonight. My name is Chris Dingman. I'm going to be giving you a brief overview of our technology, the Prophet platform, and our current non-small cell lung cancer test. And then joining us is Dr. Adam Dicker, who can do a brief introduction of himself as well when we get to his first slide, and tell you a little bit about himself and his involvement with OncoHost, but also his primary world as a treating physician, where he will go into one of our new papers, decoding the resistance to inhibitors and also future indications. Can you guys mute? I can mute everybody if I have to, but if you could go ahead on mute, just because we have a lot of people, that would be really cool. So I think we have Laura Sanchez. If you're there, can you mute? Laura? Okay, let me go ahead and figure this out. I'm not sure how to mute everybody. Let's see. Laura, if you're there, Sanchez, can you mute? Anybody can put in the chat from my team how to remute everybody. That would be helpful because it's not
I'm
showing.
here. I'm sorry.
Okay, thank you. All right. So as we get started again, Dr. Dicker will be going over the new paper and also future indications. So I'm going to start off the conversation and focus in on a very specific patient population that we're going to be talking about, that I'm going to be focused on, which is newly diagnosed metastatic non-small cell lung cancer patients. So this first line treatment decision. And the chart that you're looking at right now shows the NCCN and ASCO recommended options for treatment based off of PD-L1 ranges, both PD-L1 negative, 1 to 49, and greater than 50. And I think one of the takeaways here is that the preferred, there's a decent amount of green, but there's also a lot of blue, other recommended options for you to choose from. The majority of people we speak with, there's a lot of Pembro in the first line setting for PD-L1 greater than 50, and then there's Pembro plus chemo. But the question then becomes, well, when is it right to add a CTLA-4? Should we be looking at Checkmate 9LA or Poseidon or Empower regimens? And if so, how can we better choose which of these regimens to use when PD-L1 alone doesn't seem to be enough? And additional biomarkers are needed, and that's why we're here today to talk to you about the Prophet non-small cell lung cancer test. A very brief overview. All the data that we're going to go over today comes from a prospective observational trial called the Prophetic trial. And in that trial, which has been ongoing for almost 5 years, plasma samples were collected on patients, and then those physicians treated the patients as they normally would. They didn't have any of our information. We were gathering information ahead of time. And that was from over 40 sites around the globe. So a very nice representation of the patient populations. And ultimately, what OncoHost is doing is using system biology, machine learning to study the plasma proteome. And from that clinical trial, using a retrospective analysis of our own prospective trial, they were able to develop a commercially available test called Prophet non-small cell lung, which is entirely blood-based. The reason the company chose to focus on lung cancer as its first predictive assay to be released is because 80% of metastatic lung cancers do get first line immunotherapy. And current biomarkers, PD-L1 and TMB, are inadequate, providing inadequate insight to truly guide treatment decisions. Additional biomarkers are needed. That's why we're here. And I think what's really unique about the Prophet platform and using plasma is that it allows you to really look at the tumor, the patient, and the therapy. So you're really getting a more holistic viewpoint. PD-L1, TMB are there and designed to tell you who should do well on PD-1, PD-L1 inhibitors. The question is, how come somebody then with a very high does not? And what we have set out to do is find these resistance mechanisms and what's actually happening with these patients so that treatment can be better guided. So the first test, the Prophet non-small cell lung cancer test, again, to repeat, is a plasma-based predictive biomarker for immunotherapy. It's a decision support tool. It is ordered at the same time as NGS and PD-L1. So at the same time that NGS and PD-L1 are ordered, the Prophet test is ordered because all of this information should be in front of the physician at the same time. It takes about 8 days for the testing to take place, and then you have a result, and it comes in the form of a Prophet report. Now, I'm going to show you the profit report up front so that you have a good understanding, and then we'll go into the science behind it. The test itself comes back very simplistic. We've heard from a lot of physicians, I want to be able to look at a report, use the information of it quickly so I can make decisions and add it to the decision-making process that I'm currently using. So the test comes back either positive or negative. A negative is a profit score between 0 and 5, and a positive is a profit score between 5 and 10. But you actually get your patient-specific profit score. Why? Well, because what this test is actually doing, it's predicting a patient's probability of being progression-free at 12 months. It's predicting the patient's probability of progression-free survival at 12 months. Patient with a 0 has the lowest probability, and a patient with a 10 has the highest probability, and everybody else in between. So it's a scale. However, PFS does not always correlate to overall survival, which is why there is a cutoff point between positive and negative. When you combine the negative or positive result with a specific PDL1 range, we are able to provide you with overall survival results that can help guide treatment decisions. Monotherapy, for example, versus adding chemotherapy. I'll get into more of that in a moment when I dive deep into the data around the Kaplan-Meiers and the overall survival. And again, if you have a question at any point, feel free to stop. Now, all of the data that I'm going over is published data in peer-reviewed journals. So very important to have your analytical validity. How reliable is your proteomic platform that you're using? What is the clinical validity of it and the clinical utility? A decision impact trial. How often is this changing the treatment decision in patients? And then what Dr. Adam Dicker is going to be spending a good amount of time is, okay, you've identified these proteins, you have this algorithm, you have this predictive assay, but what do the proteins actually mean? And Dr. Dicker is going to get into that a little bit deeper. Again, the data all comes from this prophetic trial, this prospective observational trial where samples were collected before treatment began. And the test was developed on 228 patients. And once the test was locked in, it was then blindly validated on 272 separate patients. So you have both a development set and a blinded validation set on two different groups of individuals. I'm going to give you a very high level view. When you think of an EGFR mutation or a KRAS mutation or an ALK mutation, it's very clear you have this, you get X therapy. A little different in what we're doing because we're talking about immunotherapy and we're looking for those patients that are going to be resistant to the immunotherapy so that we can help you make your treatment decisions for them. So 388 resistance-associated proteins were identified. So this company actually, on just 200 microliters of plasma, can identify they have 7,000 proteins they can look at. But during the development process, 388 proteins were identified. These were the proteins that had the largest difference between somebody that was progression-free at 12 months and somebody that was not. I'm going to pause there for a second and remind people if you could mute whoever is a 121-384-13780, if you could mute your phone, that would be great. So again, we did not select these proteins. They were selected at the process. This is a machine learning process. Which patients have the largest difference? Which proteins have the largest difference between somebody that's progression free at 12 months and somebody that is not? These are considered RAPs, resistance associated proteins. So out of the 7,000, there were only 388 that mattered. These make up the algorithm. Not every protein is equal. Some are weighted more than others. But ultimately, a patient that does not have a lot of these RAPs expressed, this is somebody that has a higher probability of being progression free at 12 months, whereas somebody that has a lot of these RAPs has a lower probability. So once those resistance associated proteins were locked in, the algorithm was defined, built, It was then time to blindly validate this assay. You got one shot with these patients, 272 patients, to blindly validate it and show that it is an accurate test, that it actually does the job you set out for it to do. And that is exactly what happened in the validation. So the 272 patients, again, these patients from the prophetic trial, they're stage 4 metastatic. It's a real world trial. So they are on either pembro alone or pembro plus chemo. And you can see that the predicted clinical benefit, what the test predicted the patient's probability of progression-free survival would be at 12 months, matched almost perfectly with what was observed in the actual trial. The R squared is 0.98, one being a perfect match. And when you look at this, you can see that at the bottom left, these are the zeros in the profit score. In the top right, these are your tens, right? So ultimately, this line is your profit score. So then again, progression-free survival does not always correlate to overall survival. So the average clinical benefit rate was used as the cutoff point between positive and negative. And then those positive and negative groups were compared for overall survival. And you can see that with a hazard ratio of 0.51 and a p-value of 0.001, you have 26 months survival in the profit positive group and just under 11 months survival in the profit negative group. So you know prognostically, a profit negative patient is not going to do as well as a profit positive patient. But is this predictive for immunotherapy or is chemotherapy's role in this? Is there a prognostic factor in this? So 85 patients that were treated with only chemotherapy from a separate group outside of the prophetic trial were run. This was a group from 2016, I believe. So there was enough patients that did not get immunotherapy that had metastatic non-small cell lung cancer in the first line setting, chemo only. And you can see that this algorithm, the same algorithm, does not have any predictive capability. Therefore, we know that this test or suggests that this model is predictive for PD-1, PD-L1 inhibitors. There were some patients, about 5%, that were on a PD-1. The next question we wanted to ask is, does this tell us something different than the other tests that are out there tell us? If it says the same thing, we don't need it. If it looks at it completely differently, it has therein lies the value, and that's exactly what you see here. You see that there's no correlation between a profit result and the PD-L1 and TMB score. Again, as I said earlier, PD-1 is a single protein that's designed to identify which patients should do well on immunotherapy. What it's not able to do is identify those patients that have all these resistance mechanisms. So despite having a high PD-L1, for example, of 100, are still going to be a profit negative. And again, the profit score, remember the cutoff is the average clinical benefit rate was about 26.7%. So everything below this line is a negative, everything above this line is a positive. So you have a lot of PD-L1s, 100, 90, 80, 75 that are actually profit negative and are not going to have good clinical benefit on the immunotherapy. And the same goes for TMB. So we know that it brings that added value. But the company didn't stop there. The company said, how is a physician going to be able to use this in their clinic to make current treatment decisions for their patients? And that's where the clinical utility information really comes in strong. If you look at the patients in the clinical trial that just had a PD-L1 greater than 50, there were 213 of these patients. And then you look at the patients that were profit positive versus the patients that were profit negative. The patients that were profit positive, and it's almost a 50-50 split, so it's not a small amount of patients. The patients that were profit positive saw no statistically significant difference in overall survival when they got ICI plus chemo or ICI alone. You can actually see numerically the mono group had 42.7 months survival and the combo group 35 months survival. So numerically, there's a big difference, but statistically, again, there's no difference between these two groups, suggesting that if your PD-L1 is greater than 50 and you're profit positive, monotherapy is the right choice for you. However, with monotherapy being the true go-to in a PD-L1 greater than 50, the question becomes who should not be getting monotherapy? Who should we be adding the chemo to? And you can see that if they're profit negative, they did very poorly on monotherapy, 11 months survival. Again, because these patients have those resistance mechanisms that were not picked up before that are now being picked up by the profit test. So mono to mono, if everybody got mono that had a PD-L1 greater than 50, you can see that the profit positive group is getting 42.7 months survival and the profit negative group 11.1. And then the question became, okay, is there any indicator of if we're just looking at the profit positive, PD-L1 greater than 50, and I'm sorry, yeah, the profit positive overall survival benefit from monotherapy in the PD-L1 greater than 50. What is that related to? And you can see that the survival benefit is related to the profit positive result, despite brain mets, bone mets, smoker, non-smoker, ECOG, squamous or non-squamous. You can see that the squamous crosses a little bit here, and that might have something to do with the N. It deserves additional validation, and certainly more research is going on there, but there are no underlying factors that would have led to that survival advantage other than the fact that they are a profit positive patient. So with the profit test, there's a lot of clinical utility in that PD-L1 greater than 50. There's also significant utility in the negative and in the 1 to 49. The 1 to 49 is the group that has the least amount of utility right now, but there is growing data here for us. But what you can see is that a profit positive patient is not the same as a profit negative when treated with Pembro or ICI plus chemo. ICI plus chemo in a profit positive group, they're getting 28.2 months. So the sort of survival that you would expect out of a PD-L1 high patient, you're seeing in the 1 to 49 profit positive. But the profit negative group, they're only getting 11.5 months on Pembro plus chemo. And again, chemo is the comparator, and I don't really think that's what's the most significant comparison here, because a lot of people are not going to use chemotherapy in this group alone. What's important to point out here is that there's a statistically significant difference in overall survival between the profit positive and the profit negative patients on the same therapy. And obviously there are, things you can do with that. We can leave that to discussion, but there's certainly not every patient is treated the exact same. Some are refusing therapy, some only want immunotherapy. Might you be able to use the information to help guide some of those treatment decisions? The PD-L1 negative group, very, very interesting group. All the PD-L1 negatives that were profit positive had 23.2 month survival on ICI plus chemo. So really good results. Matter of fact, if you think about it, and you would obviously expect a patient with a PD-L1 1 to 49 to do better than a PD-L1 negative on Pembro plus chemo. But that's not the case. This PD-L1 negative group that's positive, profit positive with 23.2 months, if you go back to the 1 to 49 group, you can see the profit negative only 11.5. So over a year additional survival, even though they're PD-L1 negative. The profit negative group, however, very, very poor overall survival. Might this be a patient that's considered for a clinical trial, alternative therapies? That's again for you guys to decide what you want to do with it. But what's important to point out is a profit positive patient is not the same as a profit negative patient. And as we discussed in the very first slide, you have options. In the PD-L1 greater than 50 group, when you exclude, if you didn't have the profit, you'd have this question mark of mono versus combo. Of course, you have factors that you're looking at, age, performance status, all of that's important. But ultimately, when you're making that decision, I'm going to give them mono, knowing that their profit negative might change that decision, knowing they're going to need the chemotherapy in order to get the overall survivor you're looking for. And inversely, giving somebody monotherapy that's a profit positive, the results that you're expecting to see are great there. So it really clears up that mono versus combo and adds a whole new layer of information that you didn't have before. The 1 to 49, again, it really is a PD-1 plus chemo situation, a Keynote 189. And obviously, if it's profit negative, 11-month survival isn't good enough. Might you do something different there? Might you watch them differently? That's again for you to decide, but we know that there's a big difference in overall survival between the two groups. And then again, the same thing in the PD-L1 negative, where you do have more options in the first line setting, but the question mark is when to add the CTLA-4, when should I put these patients on clinical trials? And you know that a profit positive patient is going to do very well on anti-PD-L1 plus chemo, whereas a profit negative just isn't. So that concludes my section. I'm going to hand it over to Dr. Dicker. He is going to go over the resistance-associated proteins, those 388 RAPs, and now what we know about them and what we can do with that information. Before I do, I'll pause and find out if there's any questions about the data I reviewed.